everyone, and welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we will be talking about congenital heart disease, contraception, and family planning. We're very excited to be joined again by today's guest, Dr. Candice Silversides, who will address these topics. Dr. Candice Silversides is a professor of medicine at the University of Toronto, the Miles Nadal Chair in Pregnancy and Heart Disease, and the director of the Cardio-Obstetrics Program at Mount Sinai Hospital. She works at Mount Sinai and Toronto General Hospitals, specializing in pregnancy and heart disease and adult congenital heart disease. She's the editor-in-chief of the Journal of the American College of Cardiology Advances. She has published extensively in the field of cardiology and contributed to many of the international practice guidelines related to adult congenital heart disease and pregnancy and heart disease. She was awarded the Canadian Society of Cardiology 2023 Achievement Award for her contributions to the field. Without further ado, we'd like to welcome Dr. Candice Silversides. Hi, Dr. Silversides. Welcome back to CHD Unpacked. Thanks so much for joining us today.
Oh, thanks for having me.
So in this episode, we're going to be talking about contraception and family planning in the context of CHD. So to start this off, just wanted to ask, what contraceptive methods do you usually recommend for women with CHD? And if you can speak to some of the risks that they pose.
Yeah, so I think my most general recommendation is you should find the form of contraception that you're most comfortable with. So, there's a number. The old tried and true is barrier methods like condoms. Then obviously there's different forms of pills, oral contraceptive pills. Some contain estrogen, which is a hormone that has some issues, and I'll talk about that in a minute. And some don't contain estrogen. Then there's other options that are longer acting. So things like IUD, where you implant a coil in the uterus, or there's injectable forms of contraception. So there's quite a few different options. I think, again, you should find the one that's right for you. But from a cardiac perspective, I think there's two main issues we think about. First of all, we think about what's reliable, and then we think about what's safe. The reliability, from my perspective, from a cardiology lens, is that if you have a condition that you really do want to avoid pregnancy, or even if you just personally want to avoid pregnancy, there's some forms that are more reliable than others. So, for instance, condoms have very high failure rates. Depending on which kind of textbook or paper you read, the failure rates can be as high as 30 or 40%. So that means many women can become pregnant using that form of contraception. And certainly, if you really want or have to avoid pregnancy for health reasons, that would not be a great option. There's other forms of contraception that are much more reliable, like IUDs, which are extremely a reliable form of contraception. So that's reliability. That's one aspect of what you need to think about when you're thinking what's best for you personally. And then the other is the safety issue. And from a cardiac perspective, again, the good news is that most forms of contraception are good for women with heart disease generally, but there's a few specifics that might be relevant to you in terms of cautionary forms of contraception. So the main one being contraceptive formulations that include estrogen. So estrogen, again, is a hormone, but the problem with estrogen is it's great for as part of a contraceptive. However, it is associated with blood clots. And so if you have a heart condition, or if you're prone to getting blood clots, you wouldn't want to take that form of contraception. So those are the typical birth control pills. The large majority of birth control pills do contain estrogen. So if you had heart conditions such as a heart condition where you've had a blood clot in the past, you don't want to take a medication that makes you at risk for having another one. Some arrhythmias, like atrial fibrillation, can be associated with blood clots. It's why you'll often be on a blood thinner with that, but you may not want a form of contraception that predisposes you to get blood clots. If you have a valve made of metal, a mechanical valve, those mechanical valves, you do not want blood clots on them because it can be very dangerous. So there you would avoid it as well. So again, there are some safety issues that you want to think about, but a big one is estrogen formulations. The other issue I would like to highlight, although this is not really common, but there are some congenital heart conditions where putting in IUD, you want it done in a setting where it's at least a safely monitored setting. So
Okay.
many times you have an IUD put in a family doctor's office, and that's perfect. However, if you have pulmonary hypertension or if you have a Fontan circulation, it would be good to coordinate that with your cardiologist as well, because sometimes doing that procedure can drop your blood pressure and drop your, and you can have a difficult time with that procedure. So you want to do it in a setting where there's some backup if need be.
And in terms of a procedure like that, because it is a little bit more invasive than taking other kinds of birth control, is there any risk for infection? I know endocarditis is something that patients with congenital heart disease might be worried about
Yeah.
in certain contexts. Is that relevant to the placement of an IUD?
Yeah, so there is no or there's no antibiotic prophylaxis with IUD placement, but important to know.
Hmm. And in terms of types of congenital heart disease that are more prone to blood clots, can you speak to some that come to mind?
Yeah, so the mechanical valves, as I said,
Mhm.
we also worry if you have Fontan circulation, which is kind of a slow blood flow circulation that's prone to clots, even outside of using estrogen containing formulations of contraception. So Fontan circulation, sometimes it can be an issue. In congenital heart disease, where you've had recurrent arrhythmias, especially atrial fibrillation, I would think twice about using an estrogen formulation. Now, by the way, I said birth control pills, but not all birth control pills contain estrogen. So there is the option of getting progesterone only birth control pills. And that might be a pill for you instead of getting something, as you said, is a little bit more invasive like an IUD.
Hmm. And in terms of IUDs, I know there's a couple different types. Can you explain the difference between them and if maybe one form is safer than another form, or if any difference exists in terms of
Yeah,
risk?
some IUDs have coating on them, some do not. They're just made of metal.
Mhm.
But I would say from a heart point of view, either are fine. You should talk it over with, usually it's going to be your family doctor or maybe your obstetrician and gynecologist, but whoever you talk it over with, you can pick an IUD that you think is best for you, but there's no difference in risk from a cardiac perspective.
Okay. Thank you for outlining all those different types of contraception. For women that are thinking about starting any form of contraception and they have some questions in regards to a timeline, do you have any recommendations in regards to when someone should start contraception or when they can discontinue it when they're thinking about pregnancy?
Yeah, so the most important principle for starting is whenever you think you're going to be sexually active, and the sooner the better that you start that conversation, just because it takes time for you to understand what the different options are, what's best for you, and select the form of contraception you want. But that will be different for different people, but make sure when that time is that you start discussing it. You may discuss it again with your family doctor if you have if you have the opportunity and you can discuss it with your cardiologist, that's always optimal as well, because they can offer their opinion about whether or not any of the specific forms of contraception they would not advise in your case.
Mhm.
In terms of when to stop it, it really depends. And if you want to stop it because you're thinking of having a pregnancy, it depends on what type of contraception you're using. So, for instance, if you're using condoms, as soon as you stop using them, you can get pregnant. So, plan accordingly. If you're using birth control pills, it may be a few months before your hormones and your cycles are kind of back in regular mode and you get pregnant. So there you may need a few months lead time. And then some forms of contraception. There's injectable forms, which are longer acting injectable forms of contraception. Sometimes those do take longer before you can get pregnant after you've been using them, a number of months in some cases. So again, it really depends on what form of contraception you're using. Um, but you do have to keep that in mind because some of them you can get pregnant instantly if you stop using them.
Okay. Thank you for making that clear amongst the audience. And in terms of family planning in women that have stopped their contraception and they're looking into the future and wanting to plan for a family, are there some factors that are taken into account for family planning in those with CHD? Just some things to have early conversations about, per se.
Yeah, I think you want to decide if pregnancy is for you. And so what you need to do is understand what the risks are and whether or not you find those risks acceptable. So it's always good to start having this conversation with your cardiologist and find out what they think the risks would be for you. So first of all, find out how it might impact your health. I think another aspect is understanding what might be the risks from the baby's perspective. So in general, women with heart disease tend to be at a little higher risk at having babies that are born low birth weight or premature. So that's just a risk to understand. But maybe what the bigger risk I think that people really have on their mind is the risk of transmission of heart disease to their offspring,
Mm-hmm.
which usually is in the range of 3 to 5% with most forms of congenital heart disease. But there are some forms of congenital heart disease where transmission is to 50% of the kids, or 1 out of 2% of the kids will have the same heart defect as their parents. So it's important again to talk over with your cardiologist about your specific form of heart disease and what might be the risk of transmission to any offspring. And those are really just so you start to understand, hey, what does a pregnancy entail and what will be the risks for me and my kids? But then the other issues you want to start thinking about is, it's always good to go into pregnancy in the best possible shape you can. So
Right.
you might want to talk to your cardiologist and say, hey, I'm thinking about it. Is there anything I can do to kind of get myself in the best possible shape for it? There's always general kind of motherhood things, be healthy, eat healthy, exercise, all that kind of stuff. If you're really targeting getting pregnant in the near future, you probably want to start taking prenatal vitamins with folic acid even before you're pregnant. It's always good to have those on board. And then, kind of, there may be more complex issues. You may have a genetic condition where you may want to see genetics in advance to talk about whether or not there's any genetic issues that you might want to address. So there may be specific things for you and other specialists that you may need to see in advance for you to collect as much information as possible. And then the last aspect I'd say, just in terms of kind of rounding off the things you want to know, is are you also on medications that are safe to use in pregnancy? And if you're not, you may have to switch to other medications that are safe for both you and the baby during pregnancy. So you can see there's quite a number of things that you can discuss, but the more you know, the better you will walk into that pregnancy being prepared for. And honestly, the more you know, the more safe of a pregnancy you will have.
Right. And that list of questions, as you mentioned, is going to vary depending on the person.
Yeah,
And as we kind of know in CHD, it can be so variable from person to person in terms of the combination of congenital heart defects that they might have and the types of operations or procedures that they've had to address those and then the medications that they're on. So just to touch on the medication piece,
yeah.
are there specific types of medications that you can highlight that aren't safe in pregnancy that someone might be on?
Yeah. So there's medications that are either used for weak heart muscle or high blood pressure called ACE inhibitors, or they're called ACE inhibitors or angiotensin receptor blockers. Those are two different types, but we typically don't use those in pregnancy because they're associated with um, fetal kidney defects and other congenital defects. We also tend to avoid an arrhythmia medication called amiodarone if we can. Some people might be on amiodarone and we tend to try and switch it if it's feasible. There's other medications specifically for weak heart muscle. For instance, it's called spironolactone. that you would probably stop in most cases before you got pregnant. If you have pulmonary hypertension, there's some pulmonary hypertension medications that we do not use in pregnancy. So those would need to be stopped. Some can be used, but some can't be. So it's kind of a little mix. It's mixed for arrhythmia, or it's medications for arrhythmias, for heart failure, for pulmonary hypertension. It's all, my recommendation would be there's a number of them. If you have any of those kind of broad categories, or honestly, if you're on any cardiac medications, I think it's always good to chat with your cardiologist and find out if any of the ones you're on could potentially be problematic. It's also important, even if you're not immediately planning a pregnancy, but I think also just to understand, like, are you on any medication where it's really kind of fundamental you're also on contraceptives, because you don't want to accidentally get pregnant and have a baby with a birth defect. Because, as much as we talk about planning for pregnancy, and I'm so happy you're doing these podcasts, they're perfect and they're great. But the reality is many people have unplanned pregnancies. Sometimes they just happen for many different reasons. And so I think what's important is understanding, are you on a medication where, should that happen, is it problematic? And, what are you going to do to make sure it doesn't happen?
Okay. Yeah, I think that this discussion is important to have, early on, and so that people are aware of things to look out for. And just based on the medications that you mentioned, are any of them important to discontinue a certain period of time before someone is getting pregnant, or is it safe to just stop it right away when you're thinking of
Yeah,
that?
well, incidentally, I didn't cover every medication. I mean, the medication list is quite long, but those are kind of key cardiac ones. What I would say is, some of them we actually you keep using until you. Oh, and I forgot one other important one: blood thinner. There's a blood thinner called warfarin that can cause birth defects that we tend to come off of it if you're on a higher dose. But anyways, back on track to timing of things. There's some medications that we actually don't stop until you become pregnant, and then we stop it. So for instance, that's what jotted my mind about the warfarin. Warfarin, you would stay on it. When you get pregnant, we talk about coming off it during the period of time when the organs are forming. We call that organogenesis. That means the organs are forming. And so we stop it during that period of time, and then you may decide to restart it after. So some we don't stop till you're pregnant. Some of them we would stop before you got pregnant. And rarely do we need to stop way in advance, but one medication that we would want to stop a reasonable period of time is that arrhythmia medication called amiodarone, because it does take a while to clear from the system. So, most of them we can stop a month or two before you get pregnant, and it's fine as a general principle, with a few exceptions that need to be stopped longer than that in advance.
I think it's great to know for the audience that, medications will behave very differently from one another, even if you're on medications for a heart condition, just like someone else. The type of medication might behave differently in terms of how long it stays within your body and interactions with other medications, and the timing that you're on it, like pertaining to organogenesis, can really vary between medications.
Exactly. That's a take home point. There's so much variability. And, I keep harping on the same thing, but talk to your cardiologist. They
Right.
will, or your obstetrician or your family doctor. There's a lot of very knowledgeable people that can help guide timing of things.
Yeah, for sure. And I just wanted to touch on the piece that you mentioned earlier about transmission of a congenital defect from a parent to their child.
Yeah.
And you mentioned that there's some that have higher rates of transmission or higher risk. Can you give some examples of some types of congenital heart disease that might be on either end of the spectrum in terms of risk of transmission?
Yeah. Okay, so I want to start on the low end of the spectrum. First, I want to say, even if you have no parent with heart condition, the chance of getting or of being born with a congenital heart defect is about 1%. That's kind of the baseline rate in the population. So it increases in general in parents with congenital heart disease for their offspring to around 3 to 5%. That's kind of the general ballpark range. But even without a parent with congenital heart disease, there's still that background 1% chance of being born with congenital heart disease.
Mhm.
Now, those higher risk conditions, the ones I'm going to focus on here are called autosomal dominant. So that's where there's a 50% chance of transmission. But a classic one would be a defect called 22q deletion syndrome, which is associated with tetralogy of Fallot and other congenital heart defects. But that one is transmitted in that 50% transmission pattern. Marfan syndrome and some other inherited aortic disease conditions. um, there's some heart and muscle conditions like hypertrophic cardiomyopathy that are transmitted in that same 50% transmitted pattern. And there's some genetic syndromes that also have congenital heart disease as part of a whole syndrome where we see that transmission pattern. So again, the list is pretty long. I've really only touched on a couple examples just to say, hey, it could be a congenital structural defect, an aortic problem, a muscle problem. There's lots of different variations, but I think it's important to talk to your cardiologist. I would add one other thing for you as a patient. When you're thinking about transmission within, what would be the chance of transmitting it to your offspring? Well, it's important that we think about what kind of heart defect you have, because some are more inclined to transmit in different fashions. So, Marfan syndrome is typically 50%, but in many cases, things aren't in such a simple pattern. And it's really also important to think about your family history. And so when you're talking to your obstetrician or family doctor or cardiologist, remember to come with information about what else has happened in your family. Try and collect that information, because the more you know about your relatives, the more people will be able to tease out exactly what your risk of transmission is.
Yeah, I think that's a really important piece, and maybe just thinking about your own family tree in a general sense, and even outside of the context of congenital heart disease, what other types of um, diseases or conditions kind of run in the family that could potentially also pose a complication if you do have a congenital heart defect.
Yeah, absolutely. The more this is all the same principle. The more you know, the better. And the
Mhm.
more you know about your family tree, the better off you will be to figure out things in an informed way.
Right, right. And do you have any recommendations for men or women who have CHD and are actively trying to start a family, or for those that might want children in the future but are not trying to get pregnant right now, both from a medical perspective or even from a social perspective, some of the things that people might be struggling with?
Learn as much as you possibly can. The more you know, the better off you are. So just like we're having this conversation now, try and learn as much as you can about your heart condition, again, what runs in your family. Remember, it's not just about the mom, it's about the dad's side too. So make sure, if you're a woman, that your partner also goes and check what runs in the family. And that would be my biggest take home point, is that start talking, start trying to find out as much information as you can so you can make an informed decision about what's right for you. And then I guess the only other thing I would say is, at least from a woman's perspective, try and be as healthy as you can before you have a pregnancy. So, you know, diet, exercise, lead the healthiest lifestyle you can. It will translate into a healthier pregnancy.
Right. Yeah, and just like we were talking about from a holistic perspective, it's important to see things not just through the lens of congenital heart disease, but the other factors.
Yeah,
And
in the end, you're a person,
yeah,
You
yeah.
got all the everything else that everybody else tackles as well is also with you.
hmm And you kind of spoke about, different levels of risk. Is there kind of a discussion that you tend to have with patients in terms of what risk is acceptable to them versus risk that a physician might start to, raise a little bit of concern towards?
Yeah, the whole issue of risk is really fascinating, to be honest, because I think risk is so personal. And what I can tell you is, my job is to give you the facts, to maybe say, there's a 10% chance you could run into trouble. So 1 out of 10 women who have a pregnancy may run into trouble, or maybe 80% of women with your condition will run into trouble. Whatever the number is, my job really is to give you the facts so you can start processing it and decide how to make your decision. But in terms of whether or not you find the 10% risk acceptable or not, I can tell you that sometimes people will say, 10%, I'm happy with that. 90% chance I'll have no trouble, let's go. And other people will say, well, I can't stand the idea of 1 out of 10, 1 out of 10 chance I'll run into trouble. That's completely unacceptable for me. So this issue of risk is, as much as I could even add my own biases in, the reality is I shouldn't. I should give you the facts, and you should try and figure out what risk for you is an acceptable risk, because it is so variable. Some women are okay to take a bit of a risk, and some people want no part of it. But I'm going to add one other little tidbit of risk. So first of all, it's really important that you're a part of all these discussions, because this is about you. But the other aspect of risk is that, like, there is no right answer. Whatever you decide is the right answer for you. And even if it's a really high risk, if I say, look, it's a really high risk and I'm kind of worried, if you say, you know what, this is what I've always wanted to do, this is important, then my job is to say, okay, let's see how we can mitigate these risks. Let's do everything we can that we know to get you through this pregnancy safely. So you get to interpret the risk, but my job is to do my best to minimize the risks once you make a decision for yourself.
Right. And I appreciate you speaking to that, and just kind of highlighting that, this is such a personal aspect of someone's life, and the autonomy should be directed towards the individual and their family going through that experience. And I think it's really important to have conversations like this so that, when the discussion of risk comes into play, then they have all of the information and the facts that they need to make an informed decision, and to make that personal decision for themselves and for their family.
Yeah, I think what you just need to feel is that your team has your back.
Right.
Your obstetric team, your cardiac team, your family docs, that whatever you decide, they've got your back.
Mm-hmm. And to kind of help someone make this informed decision, apart from listening to podcasts or episodes like this, are there
Yeah.
other resources that you can maybe direct families to better inform them about how to make these types of decisions?
Yeah, you can find some of this information on the Heart and Stroke website. You will find some of it on the CCHA website. Um, but nonetheless, even if you find some information, remember there's still a lot of value in talking to your medical team as well, because there's always nuances and everybody's an individual. And what you learn on the internet may not always be completely relevant to your individual case. So I would say use every resource you can, but remember to talk to your team.
Great. Thank you so much. And thank you for addressing this very important topic. We really appreciate you sharing your expertise with our audience. So from
Thank
everyone at
you.
CCHA, thank you so much, Dr. Silversides.
Great. Thank you very much.